Now let's go to a much simpler thing, I think, compared to the highly complex optics, and just talk about how we can help patients can correct a phakia and an iridia at the same time. In the meantime, it is really the case that by no means every bulb rupture has a bad prognosis. It is even quite the opposite. There are then many eyes where you are really amazed yourself in the course of it, who can actually still gain quite good vision. But the road is sometimes long, because with such a dramatic bulb rupture, there are often some parts that the eye that just fly out due to the large cuts. First and foremost, the lens is usually always gone, in the case of the patients, of course, but correspondingly also the capsule bag and the zonular fibers. No matter if it was an IOL or your own lens, most of the time there is nothing left to be found. And the iris sometimes says goodbye completely. Sometimes there are still shares, as in this picture. But on the whole, these patients often need both a lens and an iris replacement. And fortunately, we can replace both of these today. There are several ways to do this, of course. And I would like to show you from my point of view, the really most elegant, because I think it's also surgically seen, the simplest way to actually do this. And both at the same time. We really have the first lens that is actually intended for, to be implanted in the eye as a scleral-fixed lens, because all the other possibilities that we have used so far, it was always tricks. How we can take the one lens, or Yamane technology, how we can anchor it differently in the eye. The Carlevale lens is the first to was actually created for scleral fixation. With these two charming tricks, so that we can also really don't need any suture fixation. And the whole design of the lens with all the big feel is also intended for them to be approximately in the sulcus range, as stable as possible to such an extent that it does not fit to any extent. And then there is the combination with the artificial iris, with the iris implant from the company HumanOptics. And I would like to show how beautiful the two can actually be combined. The first steps are always the preparation before we now go to the patient's eye. You always have to measure how big the iris implant is. The lens size is always determined by the optical diameter. In the case of the iris implant, is it so that it is always individually adapted and then, accordingly, also has to be trepanned? For this, he has to note distance both vertically and horizontally. And there are also several formulas that have been used so far, common, so that we can then subtract 1 millimeter from the diameter we measured. That is, if we have now measured 12.5 minus 1, we would trepan an iris with 11.5 millimeters. Then comes the next step. The Carlevale lens is then inserted with the iris implant, sewn together outside the eye in 4 places. I have now attached it to the Carlevale lens, also marked again, and that was already with the preparation. And then it's actually off to from my point of view, the easier part of both, because the preparation is, but something that is also time-consuming, really. In the beginning, we actually make the sclera pockets, just as we would do for normal implantation on the Carlevale lens, where these small ticks will be positioned later. Then, of course, you need a big cut in that case, because this sandwich from the Carlevale lens and from the artificial iris cannot, of course, be converted into an injector and then charmingly brought in through a small incision. But we actually need a larger scleral tunnel, so 6 to 7 millimeters. The whole package is simply implanted together in the eye in the next step. And we actually only fix it in the eye itself through these haptics of the Carlevale lens. Normally only the pure lens itself is fixed. That is, we then grab them with tweezers and then push them to the surface. And here you can see it when they lie on the surface of the sclera, and the small sides of the T are then put into the scleral pockets, accordingly. I also brought a little video here, so that you can see it a little better now. So this measurement knows how to. White is actually not that easy because trauma eyes, the bulb usually deforms to such an extent that you can. Horizontally often has a much larger diameter than in the vertical. That's over now. In my opinion, the most strenuous step of all. We have to make sure that you can actually do it as much as possible. Gets through the iris well without really damaging the tissue. And then fix these 4 places. There are the Prolene 9.0 threads. And then, ultimately, we have to work here on the patient. Also, prepare the corresponding cuts. Sometimes you can make it a bit more charming with not so much blood. Here it looks a bit, excuse the expression, massacred from. The problem, however, is that the traumatic eyes often actually already have a lot of scarring, adhesions, and that there is often a relatively stronger bleeding tendency, which you have to deal with here. But even that all stops at some point, fortunately. Chemostasis sets in. This is now the preparation of the large scleral incision, the attempts to, if possible, so that it seals better again. And that is now the decisive incision with implantation. And then you just have to grab the first haptics with the tweezers. Pull out through the sclera channel and accordingly the second one. And so it is then, actually already the surgery, as good as finished. The small T's are then sunk into the 2 sides, and this is what it looks like ideally at the end of the operation. I also wanted to tell you, show a few of our own examples that we have operated on in the clinic so far. This is now the first patient. He had a visual acuity of 0.3. Of course, this is also due to the fact that in part, because the pupil doesn't look like a pupil anymore, because from the retina the prognosis was actually good. But if I have spherical equivalent plus 13 with a phakia, and we now have them after an observation period of over a year, and we were really very happy that we were even looking forward to a visual acuity of 1. You can't expect that in every case that we end up at 1.0. But here it worked out nicely, and of course there was also. Our joy is very great. Of course, the cosmetic aspect of what it looks like is also unimportant. And here is the comparison with the partner's eye. That you always look at it again, like the colour of the iris. Implant also looks like the other side. That would be the second case. The patient has visual acuity of 0.2, but he actually has also such a macular layer before with a few degenerative changes, so that this certainly brought with it a visual impairment. And here we already have 1.5 years of follow-up time. Visual acuity is at 0.4, so it has also become a bit more. Above all, the spherical equivalent is of course significantly less. And here in comparison to the partner eye, it really looks even better from my point of view. So the colour was really identical with the other uninjured eye. I was particularly pleased with this case because it was a young man. I think he's around 30, of course, by this serious accident that he had, actually became one-eyed for the first time. He then also had this strong corneal scar, and visual acuity was a phac at 0.4. And here we now have 17 months of follow-up time. It comes to about 0.4, 0.5 with spectacle lenses, but with a hard contact lens. He had to get used to it a bit. But with a lot of conversations, he really did that. And now he's really very, very satisfied, because he actually gets 0.8 visual acuity with a hard contact lens. And again, the comparison with the partner's eye to determine the iris colour. This case was a bit more complex. As I said, in the case of severe bulb ruptures, you can often really achieve good results, but sometimes the extent of the injury is actually quite large. This was a patient with visual acuity profile after the bulb rupture. But he had a strong bulb hypertension the whole time, probably due to ciliary body insufficiency, among other things. And then we still said, okay, let's give it a try, even if that's a bit critical. Because of course, we have to deal with such an operation. Provoke this danger even more when the pressure is already only on the 4 to 5. We actually tried and didn't gain much visual acuity 3 weeks after surgery. But nevertheless, it looked very nice from a purely cosmetic point of view. But here that was the problem. You can already see 3 weeks after surgery. That, slowly from the endothelial side, such an inflammatory reaction with membrane growth. In the direction of, over the chamber angle area, then in the direction of the centre partly also came. We then have, tries to partially remove this membrane. That's not always easy. 4 weeks after surgery, we now still have visual acuity at 0.05. but later he went into a stronger hypertension, and this membrane has remained. This is now, for example, a moment where we can really have to pay attention to these large iris implants. This is the endothelial situation. In the long term, patients have naturally the risk of endothelial cell decompensation. That is why endothelial cell count measurement is also part of every control as a standard for us. And of course, I am always very grateful when the patients still have peripheral remnants of their own iris, because then, of course, the implant is behind it, so we can get the chamber angle, and can also indirectly protect the endothelial area a bit. The last case was also particularly sad at first. A relatively young man who had Marfan syndrome and was also severely disabled, was and sat in a wheelchair, and he then fell out of his wheelchair. And then, you can see it a bit on the edge here, that his already existing artisan lens, which he already had, was then completely torn out. The iris was also gone for the most part. He had this big conal crack where all the damage is visible again. So Visus was, of course, very modest, and we still said we'd give it a try. He has also had retinal detachments twice in the meantime. And that was a relatively fresh result, still with oil. At that time, during the second vitrectomy, he had got penoidal tamponade because it was a repeated retinal detachment. And 1 month post-operatively, the visual acuity was 0.1, and we were really happy that we were now, after almost 9 months after observation with a visual acuity of 0.2 and compared to the partner eye, have actually not achieved a bad result. As I said, the young man was also very happy about that. The quality of the pictures here is not particularly great because you can imagine such a large high-tech wheelchair. You never really get it on every camera. In this respect, we have to live with a bit of blurry shots here. Yes, I would finish with that. Wanted to say again briefly that this, as I said, my own experience is that we have been able to really very elegant combination of the scleral-fixed Carlevale lens and the artificial iris. Really nice anatomical, functional, and also cosmetic results, and above all, what really is very valuable in this method from my point of view, that we have no long-term suture-associated complications, because we don't have to sew on the lens and the iris implant, in the eye. But of course, there are a few things we should pay attention to, and Carlevale linse. It is the case that there is, of course, the risk of IOL clouding, especially for the hydrophilic variant. This is the case with all IOLs that are hydrophilically made. The risk exists in principle. And with the artificial iris, as I said, we have already mentioned, endothelial cells. Decompensation can occur over time. As a rule, however, it is then cases that have actually had these implants for 10, 15 to 20 years. So it develops it very slowly. And what I haven't mentioned yet, sometimes it can actually lead to pigment dispersion. So if we still have quite a lot of our own irises, and behind it is the iris implant, sometimes contact then occurs, and then also a bit of pigment washout, and this pigment dispersion. However, this can usually be remedied relatively well conservatively. Yes, and with that, I hope that you are as convinced as I am that the two might somehow get along well with each other. And if there are any questions now, they will be happy to contact me. A few minutes we certainly have, yeah. Thank you very much.